You know, when you buy a house, you can walk through the physical structure, right? You can kick the baseboards, check the water pressure, look at the roof.
Yeah, you actually see the mechanics of what you're paying for.
Exactly. But the absolute biggest financial and, well, lifestyle purchase of your 60s is completely invisible. I mean, you can't exactly kick the tires on your healthcare policy.
No, you really can't.
But the structural integrity of what you choose right now will basically dictate the rest of your life. So today we are doing a deep dive. We're cracking open the dense, highly jargon-filled 2026 Medicare and You government handbook to map out these hidden load-bearing walls of your healthcare.
Which is so needed, honestly.
Right. So whether you are staring down your own enrollment window right now, or maybe you're helping a parent navigate the system, we're getting straight to the practical trade-offs here. It really comes down to ultimate medical access versus bundled cost capping.
And the central tension of this entire system really revolves around how you personally want to manage risk.
Okay, say more about that.
Well, it's a tug of war. It's between maintaining complete geographic and medical freedom, usually at a higher upfront premium, versus accepting the network constraints of a managed care system in exchange for, financial predictability.
Right, the classic freedom versus convenience trade-off. But before we get to that big fork in the road, we have to talk about the baseline toll booth.
The mandatory costs.
Exactly. Let's lay out the baseline numbers that almost everyone faces in 2026. Regardless of which route you take. So the standard Part B premium for 2026 is exactly $202.90 per month. And for most people, this is just automatically deducted from your Social Security benefit.
Yeah, and that acts as a silent deduction. It removes the friction of paying a monthly bill, but it also it makes the true cost of care somewhat abstract for a lot of people.
Out of sight, out of mind.
Right. Now, $202.90 is just the baseline. The handbook outlines the specifics of the income-related monthly adjustment amount, or IRMA.
IRMA. The dreaded IRMA.
Yes, exactly. Medicare assesses your modified adjusted gross income from 2 years prior. So for your 2026 premiums, the government is actually looking at your 2024 tax returns.
Okay, let's unpack this for a second. The thresholds for 2026 are $109,000 for an individual or $218,000 if you are married and filing jointly. So if you cross that line,
you get hit with a surcharge.
Right. On top of that $202 base premium. Plus, IRMA applies to your Part D prescription drug premium as well, doesn't it?
It does. And the lag time in that tax assessment is crucial to understand. Like, if you experienced a major liquidity event in 2024, maybe you sold a business or, a property, your 2026 premiums are going to spike.
Even if you aren't making that much money anymore.
Exactly. Even if your actual retirement income in 2026 has stabilized at a much lower level, you still have to anticipate that cash flow hit.
Wow. Okay, so speaking of Part D, this is where the 2026 handbook has a massive structural update. Huge.
Absolutely seismic.
Yeah. The notorious donut hole, those complex coverage gaps that honestly used to leave people completely bankrupt, it's dead. Completely dead. We now have a hard $2,100 out-of-pocket cap on Part D prescription drugs.
Right. The elimination of those coverage phases is a fundamental shift in how risk is distributed. Because once your out-of-pocket spending on covered Part D drugs hits that $2,100, your cost drops to zero.
Zero. For the rest of the calendar year.
Exactly. And what's fascinating here is how this shifts the financial burden. Historically, patients with complex conditions bore the absolute brunt of catastrophic drug costs.
Right.
But now the liability past that 2,100 mark shifts heavily onto the insurance plan sponsors and the pharmaceutical manufacturers themselves.
Okay, but, and correct me if I'm wrong, that means the insurance companies are going to try and recoup that liability somewhere else.
Yeah.
If they are eating the cost of a, say, $15,000 specialty drug after I pay my $2,000, they're going to tighten their formularies.
Oh, without doubt.
They might drop coverage for certain expensive drugs entirely to avoid hitting that ceiling, or just aggressively push cheaper generic alternatives.
Yeah, the behavioral economics of the cap dictate exactly that response. Insurance companies are going to utilize step therapy and prior authorizations far more rigorously on the pharmacy side to manage that massive new financial exposure.
It really changes the game for chronic conditions, though. I noticed the handbook also emphasizes a strict $35 per month cap on covered insulin products and it removes the deductible requirement for insulin entirely.
Right. And if we connect this to the bigger picture, removing that financial friction for insulin is actually a long-term cost containment strategy for the government.
How so?
Well, capping a daily necessity at $35 prevents patients from rationing their supply. Rationing leads to diabetic ketoacidosis, which leads to intensive care admissions.
Which cost a fortune.
Exactly. The system is absorbing the upfront cost of the medication to prevent a vastly more expensive emergency room cascade down the line. That makes total sense. So, okay, the baseline is changing, but we have to mention there is a giant, glaring warning label attached to this entire system.
The penalties.
Yes, the penalties. All of this assumes you sign up during your initial enrollment period. And if you procrastinate, the system punishes you permanently.
It really does.
If you delay signing up for Part B when you are first eligible and you don't have other qualifying coverage, you get a 10% penalty tacked onto your premium for every full 12 months you delay.
And that penalty follows you for as long as you hold Medicare. It is lifelong.
And the Part D drug penalty is just as weird.
Yeah, it functions similarly, but it's calculated at 1% of the national base beneficiary premium.
Which is $38.99 for 2026.
Right, and you pay that 1% for every uncovered month. So delaying Part D by, say, 30 months means a permanent 30% penalty on that base amount added to your premium forever. Wait, okay, I understand wanting people to sign up, obviously. But why is it a lifelong compounding punishment? That just feels incredibly brutal for what could literally be a simple administrative oversight.
It does seem harsh, but the mechanism driving that brutality is the prevention of adverse selection.
Okay, adverse selection, what does that mean for the listener?
Basically, insurance pools only survive if healthy individuals pay premiums to offset the massive costs incurred by the sick. Without severe permanent penalties, rational actors would simply wait.
Right, they'd wait until they got sick.
Exactly. They'd wait until they received a cancer diagnosis or suffered a stroke to purchase insurance. So the permanent penalty is the lever the government uses to force healthy capital into the pool.
Basically forcing you to buy in while you're healthy. Okay, so don't miss the window. The toll is paid, the baseline is set. Now we finally arrive at the actual architecture of the coverage, the two paths.
Right, the big choice.
Let's start with Path A, Original Medicare Parts A and B. The defining feature here is ultimate geographic and medical access.
It's unparalleled.
You can go to literally any doctor, specialist, or hospital in the entire United States that accepts Medicare. You don't need a primary care gatekeeper, and you don't need a referral.
Yeah, that geographic borderlessness is unmatched in the private insurance market. If your primary residence is in Ohio, but you require specialized neurological care at a facility in California, your original Medicare coverage is fully active. No questions asked.
But here's where it gets really interesting. When you look at the math of Original Medicare standing alone, it is a massive financial vulnerability.
Yeah.
Because there's absolutely no yearly limit on what you pay out of pocket. After you meet the $283 Part B deductible for 2026, you are responsible for a 20% coinsurance on most services. Forever.
And the lack of an out-of-pocket maximum is the defining risk of Path A. Medicare covers 80%, leaving you completely exposed to the remaining 20%.
Which is fine if you just need a few blood tests, right? But 20% of a $150,000 joint replacement or oncology treatment, that is catastrophic. You could drain your entire retirement savings in a single bad month.
Oh, easily.
It's like ordering a la carte at a high-end restaurant. You could order whatever you want from the menu, the quality's incredible, but there's literally no limit to the final bill.
That a la carte analogy effectively captures the dynamic perfectly. You have total freedom of choice, but unlimited financial exposure. And this structural gap is exactly why the Medigap market exists.
Right, the bumper on the car.
Yes. Medigap, or Medicare Supplement Insurance, transfers that 20% coinsurance risk to a private insurance company.
So you pay a separate monthly premium, essentially buying a prefixed dining club membership to cap that limitless bill. And once you have a Medigap policy, you are shielded.
Completely shielded from that 20%.
And the handbook lists these standardized Medigap plans by letters, right? A through N. But it specifically notes that for new enrollees, plans C and F are dead. You just can't buy them anymore. They've been replaced by plans D and G.
Yeah, and the phase out of plans C and F is another really interesting lesson in behavioral economics.
Oh.
Well, those specific plans offered first dollar coverage. They paid for everything, including that $283 Part B deductible. Policymakers recognized a phenomenon called moral hazard.
Okay, what is that?
If a patient faces zero out-of-pocket costs for a medical encounter, they are highly likely to overutilize the healthcare system, seeking care for minor self-resolving issues simply because it is fully covered and costs them nothing.
So they want people to have some skin in the game.
Huh.
By moving to Plans D and G, the patient actually has to pay that $283 deductible out of their own pocket first before the Medigap shield kicks in.
Exactly. The deductible acts as a small speed bump. It forces the consumer to evaluate whether the medical visit is truly necessary, which reduces frivolous strain on the broader healthcare infrastructure while still protecting the patient from those catastrophic 20% coinsurance bills.
That is brilliant, actually. So Path A is original Medicare plus a Medigap policy plus a standalone Part D drug plan.
Yeah.
You have ultimate freedom. You can see any doctor, and you are shielded from ruin.
Sounds perfect, right?
It does. But a $200 a month Medigap premium on top of your Part B and Part D premiums is a massive cash flow barrier for someone on a fixed retirement income. There has to be a mechanism for people who simply don't have that upfront cash every single month.
And that cash flow barrier is the precise reason Medicare Advantage, or Part C, has grown to completely dominate the market. It offers a totally different financial model for the consumer.
The famous all-in-one bundle, Path B.
Right. Under Medicare Advantage, the federal government actually pays a private health insurance company to manage your care.
So they bundle your hospital, your medical, and usually your prescription drug coverage into one neat package. And structurally, they are legally required to include a strict yearly limit on your out-of-pocket costs, right?
Yes. Because of that built-in out-of-pocket maximum, you do not need and legally cannot be sold a Medigap policy if you are enrolled in a Medicare Advantage plan.
Okay, wait. If the Advantage plan has a hard out-of-pocket cap, and they're giving away all this stuff like routine dental care, vision exams, and gym memberships, which original Medicare explicitly does not cover, by the way, who is paying for that?
That is the million-dollar question.
Right. There is no way the math works out unless someone is subsidizing all these extra perks.
Well, the underlying mechanism making those perks possible is called capitation. The government doesn't pay the Advantage plan for each individual service you use. Instead, the government pays the private insurer a flat capitated rate per patient per month.
Ah, okay.
So if the insurer keeps you healthy or manages to provide your care for less than that flat fee, they keep the margin as profit.
So they take a portion of that margin and they use it to buy gym memberships and dental cleanings, deploying those as marketing tools.
Exactly. To attract more enrollees, which brings in more flat monthly fees from the government. The perks are absolutely a loss leader designed to capture market share.
Wow.
It is highly convenient, operating sort of like a closed tech ecosystem. Everything is in one place, and the upfront premium to the consumer is often $0, though remember, you do continue paying your $202 Part B premium to the government.
Okay, so what does this all mean for you listening? If you get an out-of-pocket cap, lower premiums, and free dental, it sounds like an absolute no-brainer.
On the surface, yes.
But you can't have an a la carte menu on a capitated budget. You are trading your freedom for convenience. So what is the catch when you actually need serious medical care?
The trade-off relies heavily on network constraints. Medicare Advantage plans utilize network architectures, primarily HMOs or PPOs, to control their costs.
Let's distinguish those, because they function very differently when the pressure is actually on.
Right. An HMO, or health maintenance organization, has hard network walls. If you go outside their specific local network of contracted doctors and hospitals for non-emergency care, the plan typically pays $0.
Zero.
You bear the entire cost. A PPO, or preferred provider organization, offers a little bit more flexibility. You can go out of network, but you will face significant financial penalties in the form of much higher copays and coinsurance.
Okay, so let me throw a real-world edge case at you.
Sure.
What if I am on a Medicare Advantage HMO and I get diagnosed with a highly aggressive, rare cancer? I do my research and I discover the absolute best specialist in the country for this specific cancer operates out of a research hospital 3 states away. What happens?
Under Path A, with original Medicare and Medigap, assuming the specialist accepts Medicare, you book a flight and go. Your Medigap shield follows you anywhere.
Right.
But under a Medicare Advantage HMO, you are geographically trapped. The out-of-state research hospital is not in your local network.
And if I just go anyway?
The HMO will not cover the treatment. You would be navigating complex, life-saving oncology care entirely out of your own pocket.
That is wild.
And even with a PPO, the out-of-network coinsurance for cancer treatment could easily reach tens of thousands of dollars before any out-of-network maximums are actually met.
That is just a terrifying reality to face when you're already dealing with a major diagnosis. I mean, the gym membership is great when you're healthy, but the network loft can be catastrophic if you get truly sick.
Yeah, it really can be.
And the network isn't the only gatekeeping lever the insurers use, is it? We need to talk about prior authorization.
We do. And then this brings us right back to the capitation model. Because the insurer receives a flat fee, their primary tool to avoid losing money on expensive procedures is prior authorization.
How does that work in practice?
If your doctor determines you need an MRI, a specialized surgery, or admission to a skilled nursing facility, they must submit clinical documentation to the insurance company to ask for permission before the care is delivered.
So an insurance company actuary is essentially second-guessing my doctor.
Essentially, yes. The insurer is evaluating the request against their own clinical guidelines to determine medical necessity. They can deny the request entirely or mandate a step therapy approach, requiring you to try and fail on a cheaper, more conservative treatment first.
Wow. Under original Medicare, if my doctor says I need an MRI, Medicare just pays for it, right? There's no permission slip required.
Prior authorization is exceptionally rare in original Medicare, but in Medicare Advantage, it is the fundamental mechanism used to control utilization and protect the plan's profit margin.
Can you fight it if they say no?
You have the right to appeal a denial, yes, but the appeals process introduces massive friction and, frankly, delays into your care timeline when you might need treatment immediately.
So for you, the listener, weighing all of this, how do you make the call? It really just comes down to ruthlessly evaluating your risk tolerance and your cash flow. If you simply cannot afford a $200 monthly Medigap premium, Medicare Advantage provides a vital safety net with its out-of-pocket maximum. It is undeniably safer than flying blind with original Medicare alone and risking unlimited 20% coinsurance.
But on the flip side, if your cash flow supports the upfront cost of a Medigap policy and you place a premium on total autonomy, the ability to access any facility nationwide without administrative friction or prior authorization gates, original Medicare remains the gold standard.
It is the choice between the ultimate freedom of the a la carte menu with a dining club shield versus the highly structured, localized restrictions of the prefix bundle.
That sums it up perfectly.
But I want to leave you with a fascinating loophole we found deep in the source material. A way to actively weaponize the rules if you are turning 65 soon and are paralyzed by this choice. It's called the trial right.
Oh, the trial right. It functions as a highly strategic consumer protection.
Let's say you are first eligible for Medicare at 65, and the lower premiums of the Advantage plan are tempting. But you are terrified of the network lock we just talked about. The government actually grants you a 12-month test drive.
Right.
If you enroll in a Medicare Advantage plan right out of the gate at 65, you have exactly 1 year to evaluate how they manage your care.
And if you encounter aggressive prior authorizations or you find the local network of specialists insufficient for your needs, you are not permanently locked in.
You can pull the ripcord, you can drop the Advantage plan, revert to original Medicare, and here's the most critical part. You retain a guaranteed issue right to purchase a Medigap policy without any medical underwriting.
That is huge. The private Medigap insurers cannot deny you coverage, and they cannot charge you a higher premium based on any pre-existing conditions you may have developed during that 12-month window.
It is a one-time safety net that completely lowers the stakes of your initial enrollment. You can test the waters of private network insurance without forfeiting your right to the Medigap shield.
But if the government feels the need to give you a 12-month ripcord to escape private networks, it begs a much larger question for you to mull over. Are Medicare Advantage plans becoming so restrictive that the government fully expects you to want out?
That is a chilling thought.
It raises an important question regarding provider consolidation, too.
Exactly. Look at your local healthcare landscape right now. Major hospital systems across the country are increasingly dropping Medicare Advantage plans because they are tired of fighting the prior authorization battles and taking lower reimbursement rates.
It's happening everywhere.
So the network you sign up for today might not include your local hospital tomorrow. That is the homework you need to do before 2026 arrives. Call your doctors, call your local hospital billing departments, and ask them point blank, which path are you actually accepting next year?
The invisible architecture is shifting rapidly. Understanding these mechanics is the only way to ensure your foundation holds when you need it most.
Thanks for diving deep with us today. Take a breath, look at your local hospital systems, and go make the choice that lets you sleep at night.